So I know that Beth is pulling up the slides, but I'll just keep talking. So ultimately what we're gonna present now are, as I said, our results from our insight gathering at a global, regional, and country level, really to try to have some input into this. What we're trying to do as a work stream to inform a more people-centered immunization service experience. And so we started that at the global level, as I said, with many of you, and sort of were asked quite a bit about what you were thinking as what might be some key components that would contribute to strengthening service experience to improve immunization demand. Thanks, Beth. So we can move ahead for next slide or two. Let's see, keep going. Thank you. So at the end of our sort of global exercise, we interviewed about 25 people across various different domains. So immunization people, as well as health system strengthening, and then other domains as well. I know that we've mentioned this yesterday in our discussions, but there are a lot of other technical areas that are doing work in this, experience of care and people-centeredness that we were trying to interview and learn a bit from. These KIIs took place mostly via Zoom, and then some face-to-face. So next slide. So after all of those interviews, we had this is a list of sort of some of the key themes that started to emerge as important components of service experience to potentially consider. So we have overarching themes. We have themes that are related to sort of the health system and facility, those that are related to health worker and client, and then of course community. And then under there, you'll see more specifics. I'm gonna go through in a bit more detail each of these, but this is just an overview. And ultimately what we did here is we had this list, and then we said, okay, well now we need to go to the countries. So we designed a key informant sort of interview questionnaire based around sort of some of these themes that are coming, to see ultimately what the countries thought about whether or not these resonated or not, what was happening or not in these spaces, whether it was, and if there was anything taking place, if it worked or not. And then what follows now is some of their input. So the next slide, just quickly, as I said, we carried out key informant interviews in Ghana, Mozambique, and Nepal. Kenya, we took a little bit of a different approach. The EPI and some of our counterparts were quite busy, so we did a desk review rather than key informant interviews. But as mentioned yesterday, this table should be familiar to you. We did 55 key informant interviews across those three countries, Ghana, Mozambique, and Nepal. And then in Kenya, we yielded about 80 pieces of relevant and eligible literature from the lit review. And in Ghana, we also did a bit of a lit review. So Ghana, we did a bit of a hybrid approach. So we did 43 pieces came out of that lit review. Next slide. So the first thing we're going to talk about is this first theme here. It's kind of an overarching theme about service experience across all levels in the health system. Next slide. So this sort of probably feels all-encompassing to you, and but the idea is that are we, within national policy and strategy, any processes or initiatives that we are designing to help with service experience and demand generation, are we taking into account the end users, so the clients and the health workers as well? And there was an example that was mentioned in the lit review from Kenya that I thought was interesting to share, in the sense that they were trying to make maternal health more accessible to women. And so one of the things that they did is they abolished the user fee for the maternal health service. But so all in good faith and like trying to do something really great for the client, but what didn't happen is they didn't necessarily think through how to match this change with any additional staffing. So they were doing something to improve the service experience when ultimately it led to an increased workload for the health workers, an inability for them to maintain the quality of care because they had an influx of patients. And so that kind of resulted in a little bit of poor staff motivation. So the idea really is thinking through from top to bottom across these different policies and strategies, all the different users that would be affected by it. And then there's a question about whether our national policies on experience of care, do they emphasize or consider immunization? We know that there are experience of care and quality of care strategies taking place. In Ghana had quite a few examples of different policies, but whether or not they actually were focusing or considering specifically immunization was not clear, or it wasn't happening. So this is just sort of an overarching idea of what we're talking about in terms of service experience across all levels of the health system. Next slide. Next slide. So we're growing our visual here. So now I'm going to move into the themes under health system and facility. Next slide, please. The first one being facility environment. Okay, next slide. So we talked about this yesterday. Lubna, you made a really good point about this, and this came up many times over, that one of the key components of service experience is the environment of the facility. So we're wanting it to be welcoming, calming, and safe, something that is respectful. If it's cold outside, we want it to be warm on the inside. Caregivers in Kenya noted that one of the things that's really important to them is privacy during these immunization sessions. They don't want their kids to be exposed. Then there's the condition and management of the facility, the look, the feel, the cleanliness and order. All of these things can affect how people interpret the care that they're receiving and the immunization session itself. And then this equipment and setup of the session, availability of vaccine storage and storage registers came up across all the countries. And in Ghana, for example, they don't have, in many places, cold chain facilities down at the primary level, which requires a health worker herself or himself to go and travel to obtain the vaccines from the cold storage to then bring it back to the delivery point. This is an added burden for the health worker and something that can lend to poor motivation and affect their own experience with it. And one thing we wanted to add here too is that this box here on the left, this challenge with vaccination infrastructure in Mozambique, and this happens in many countries, but in Mozambique they have natural disasters and population displacement, and this is of itself really can affect the vaccination infrastructure, which in turn can affect the experience. Next slide. Okay, so now we have integration of immunization within a service of package of services. Next slide. This came out yesterday in our discussion a couple of different times, including when we were talking about the WHO definition of quality of care and integrated services. So the idea is that, in some countries, in some places, the clients are asking for integrated delivery of care. They have a lack of time, it's more convenient for them, but in some places, the structure or feasibility, there's limitations around whether or not that can take place. For example, in Mozambique, they noted that this is a challenge for them based on competency, for example. Also related to integration is this sort of exploration of different entry and conversion points of immunization that can affect the service experience. And this idea around exploring how the quality of the integration of immunization and other services is perceived by health workers, clients, and communities, and how that's measured vis-a-vis expectations, perceptions. We have this quote on the left-hand side, and we say, when we think about quality of care, we often overlook the quality of care and integration of services. The idea being, how does the quality of care, how is that affected when we integrate? And trying to explore a bit more around that. And then this note at the end about how the service provider interaction with clients can be compromised due to integration with an increased workload, longer hours of service delivery. This can result in stress if they are not properly equipped with what they need to carry out this integrated work. Next slide. Okay, this one now is a theme of public and private sector experience. So next slide. One of the reasons that this came up at the global level is in recognition in that some countries and regions, the private sector is starting to grow. And so it was a speculation that potentially this is an interesting and good time for us within the work stream to really think a bit more about immunization in the private facility space. Meanwhile, you have this sort of graphic on the right-hand side about what sort of rationale might go into why some clients go to one versus the other, and wanting to understand the motivation for doing that and what it is about a private facility that makes somebody want to go there or not, and the same with public facilities. So with a private facility, we have cleanliness, convenience, getting what they wanted. In Ghana and private facilities, you can get vaccines that you might not be able to get at the public facility, for example. You might have to pay a small fee, but you can still get it. A shorter waiting time, being courteous and respectful. But meanwhile, we have this issue of standardizing technical standards of care and having standard operating procedures that the private facilities have to make sure that they are adhering to WHO recommendations. And then in the public facilities, there's the idea that it's more comprehensive counseling, better screening, maybe better medical quality itself, but a need to improve interpersonal relationships and efficiency. So moving forward from this slide, we're going to move forward into the health worker and client kind of overarching leaf we have here, and what is starting to emerge as what some of you can suspect, a flower. Next slide. Health worker empowerment. This is a busy slide. I know we're all very interested in health worker empowerment. We talked about it yesterday. I kind of tried to focus a bit on the capacity building that we talked about, and then motivation. So capacity building can come from many different directions in terms of pre-service, training, in-service, the need for blended learning approaches. The idea being that if health workers have the confidence in the clinical aspects of the work, then they can, by way of that, effectively communicate with the client about it. And that would then result in more positive experience from both of them. There's this interest from the country level indicating that supportive supervision and feedback are actually really well received by health workers and can be motivating and can be a really short interaction, but one that can improve the quality of care, and it is appreciated by health workers. And then the suggestion to be making sure we're starting to create learning environment for young health workers who are posted to remote areas, who are new to the field, so that they have peer mentorship. And then across the board in all countries, this need for capacity building around IPC. And Ghana noted specifically that anti-vaxxers are an issue. And then we have this idea of motivation. And if you look at this list, I won't go into too much detail here in terms of time, but if you look at it, very few things included in here that these are suggestions or things that emerge from the countries are linked to money. It's about recognition of their performance. It's about having a good manager so they feel well supported. That can be very motivating. Providing transport to do outreach sessions or place to stay, or this last point, but the safety and security for health workers who must walk long distances. This came out of Nepal quite a bit. They have female community health volunteers who walk a long way. We want to make sure we consider that they are safe and that they have somebody to go with them if they're going for a long way. Next slide. Interpretation and perception of service experience. So next slide, we talked about this quite a bit, I think, yesterday and probably in breakout sessions, but in plenary, but this is an emerging theme of an area where we should really try to explore. Is somebody's interpretation or perception of service experience outcome-based? That is, I wanted a vaccine, I got a vaccine, this is great. Or is it more around some of the other stuff and that satisfaction and those sort of other touches around the experience itself, and wondering and thinking through how we might be able to measure that. This is something that all the countries said this would be good to measure, but we might not be doing it, or we should look at the indicators that we're already measuring or collecting to see if something can be useful. And then there's this idea we talked about as well about how the expectation might affect the experience or perception of the experience for both the client and the health worker. So, and this quote on the left came out from the desk review in Kenya, in that some marginalized groups, because they come to expect poor quality of care, they accept that, and that to them can be, an okay experience because they don't have any indication necessarily of what could be better or not. Next slide is also about interpretation of perception of service experience. I won't spend too much time on this. This is a sort of divided up by like what might be a client might be looking at or thinking about in terms of how they're perceiving the experience. And then the provider. Again, down on the provider section, you can see it's about mentorship, having access to documents to improve their technical capacity, being supported by the health system or through staffing, not necessarily monetary incentives. And across the board, this need for capacity building of health staff around IPC is highlighted as a way to ensure that both parties have a positive service experience, and that this would affect somebody's interpretation or perception of service experience itself. Moving forward, next slide. Now we're going to move on to community. So next slide. Community voice, input, and demand. Next slide. So I'm sure we all know there's a lot that we could include here. I probably could have included like 20 sides, but the idea being that we're trying to think through how we align services with the expectations and perceptions of the services from the community point of view to enable quality improvement, and thinking through how we can ensure that they are involved in how the interventions are designed and delivered and monitored. So there's some already existing approaches that have community engagement approaches, including Red Rec, which is implemented everywhere, or human-centered design, and that these can really facilitate community involvement. Another thing that emerged from across the countries is is this health committees or co-management committees through which communities can participate, again, in the planning and monitoring of health programs. These are really important mechanisms, but are oftentimes buttressed by by external support or NGOs. And we need to think through how this mechanism can be supported more internally. But one of the things that came out is that in some of these situations, sorry, there's police. In some of these situations, committee members don't always represent the community. Sometimes they're appointed. So you have these members of the committees who don't necessarily represent the community, and that can weaken the functioning of the committee itself. So it's something to consider. Next slide. And this is about feedback, really, and it's about community engagement and the monitoring of the quality of the service delivery, the experience, and how things are going. So here in this kind of graphic, I have a couple of different examples. Community scorecards came up in all of the countries. A lot of times they were supported externally, but it was thinking through a way about whether or not they can be integrated into a system that already exists. MNCH satisfaction cards, mothers groups, fathers groups, using the community health worker or the person who interfaces with you as sort of the liaison between the system itself and the community as a way to feed up information or feedback. So there's lots of different ways in which this is already happening, but it's not always super consistent and sometimes is dependent on outside functioning. But the idea is not only to solicit the feedback, but to make sure that you are circling back around, right? So it's not just take from the community, but making sure that you're going back to the community afterward and having in these feedback loops where you've shown that you've considered their feedback. Okay, moving forward. Next one is workplace community. This is our last little theme in community. So moving forward to the next slide. This is an interesting, So what we were sort of talking about really is thinking about considering the health provider ecosystem holistically. Who are the health workers and what affects them? So gender plays a big role here, right? So we know a lot of health providers or nurses are women. What is it like for a female healthcare worker? What do they need? Again, this example from Nepal, that a female community health volunteer who travels a long way might need somebody to accompany her for that. But there's also this idea that in a lot of times when you're a new health provider, you're sometimes stationed out to a community you're not familiar with and you don't know anyone. And there was a suggestion that we should make sure that there's housing provided for them, and that's clear. They know when they get to their community, like where they're going to live, and that doesn't always happen. So it's sort of thinking about the things that the health worker needs in order to engage. Also around this workplace community is this idea of creating a sense of community amongst the health workers and the providers themselves, and really allowing and creating a space whereby they're able to interact, engage in peer learning, collaborative learning as a community. In Kenya, there was like one example of like an optometrist community of practice that just kind of started, I think, in 2017. So it's a new concept there. But what isn't new in a lot of places now, or is really emerging, is this engagement over WhatsApp to exchange ideas, share information, and engage in informal peer mentorship. This is something that's really well received and is especially important right now in COVID times when we can't be meeting at review meetings or et cetera, and in person. So there's just something really important, I think, about making sure that this workplace community is established and functioning and creating an environment for health workers. Next. Okay, so this is where we ended up. We have right in the middle here, we have service quality and satisfaction that just emerged. So next slide. The reason that we did this is that quality is over and over again, as we know, it must be at the center of everything that we do. And there's, of course, I know Francine probably has a lot to say about this in her work, but the idea that immunization quality needs to be defined and the standards need to be understood. There are existing things at the global level, like the WHO quality of care standards, that we can start from or use. It might not be immunization specific, but it's a tool that we can have as a starting point. So on the left-hand side are a couple of other different ideas as to where we could start. But if we move on to the next slide, one of the things that really emerged around the quality of this interaction and the service provided was IPC and interpersonal communication around immunization. And You know, the quality of interaction, this quote here is really important and it needs to be improved. And this idea that counseling is really weak came out across all the different countries. Caregivers don't want to ask questions because of a poor provider attitude or perceived provider attitude. They fear how they might respond. There's issues around language and literacy and cultural barriers on both the part of health workers and clients. If you're sent to a part of the country where you're not from, you're not understanding the cultural nuances there as a health worker. In some places they're sent where they don't even speak the language. So then how can we equip the health worker to deal with a situation like that, whereby they can't speak the language of the clients that they're supposed to be serving? So this emphasis on interpersonal communication skills versus mentoring skills versus clinical skills, it all kind of comes together. And we want to make sure that if we're pushing for improved interpersonal communication, that there's also managers and supervisors who know how to effectively monitor that. Moving forward. Okay, so this is where we are. And right at the center now, we have people-centered immunization service experience. So this visual encapsulates all the stuff, all those themes that I mentioned at the very beginning and we just went through around what are key themes and areas and components to consider when we're thinking about service experience. And across the board, these resonated with all the countries and the key informant interviews, some more than others. Integration, for example, of immunization was not as, I don't want to say, it didn't resonate as much, just for various reasons. In Kenya, I think there just wasn't a lot of literature on this yet, so that might be why. It doesn't mean in actuality it doesn't matter. And then in Mozambique, it seems that a lot of the KIIs were saying we need to focus on the facility environment first, and improving that and making sure that there's strong referral between the different services within the health facility before we move toward integration of services in the health facility. So moving forward, there were some additional themes that came out of the country interviews that we did not include in our original graphic. And so our flower grows. So moving forward, to the next slide, we have advocacy, governance, leadership, and financing. And if we move forward one more slide, I won't go through this too much in detail, but this red box on the left about the 4 elements of advocacy, governance, leadership, and financing, they're all needed and they all interact with each other and are needed to support demand. This might be linked a bit to our service experience across all levels of the system theme as well. But in Nepal, this is really important because of the federalism. There's frequent turnover in the government leadership, so you need to have continued advocacy to them on the importance of immunization so that we get so that funding is provided to it. And so all of these things kind of converge in this space of being able to advocate for immunization to the government and the leadership to make sure that there is financing for it. Next slide. We grow again. Now we have on the bottom left, community actors and stakeholders. So next slide. There are community members who are not necessarily the health workers or community health workers or the client. There are other people who are involved in this space and who need to be considered and can contribute to and affect service experience and demand. We have corporate actors who are involved in social investment and funding, and this can be really useful for sustainable financing for immunization. There's academia who can be involved in research. There are traditional and religious leaders. There are influencers in communities who double as community leaders as well. So in Ghana, the case of Queen Mothers, they can influence anti-vaxxer groups and social media campaigners. So it's important for us to consider these different stakeholders when we're thinking about service experience. And then this box on the right, this idea of outsourcing services like transportation and the use of community resources like motorcycles and vehicles to get the communities involved and empower them to engage in the health system and be part and parcel to it. Next slide. We grow again, logistics and resource availability. I suspect that this might need to be like a root to our flower, but we'll move to the next slide and quickly go over, we all know how important it is to have cold chain, to have supplies, to have the commodities. Without any of this, we can't vaccinate anyway. And so there's this quote that that one of our KIIs, I think in Mozambique said, all of the service experience diagram components only make sense if vaccines in a functional cold chain exist. So of course, taking into account that this is important, and without this, then the rest of it can't happen. Next slide. This is our last one, outreach services needed a little bit of a bud. So we added that here, and the next slide, just to explain quite quickly. The outreach services are seen as an extension of the health facility. So the experience of care that one has in an outreach setting can also influence how they utilize services provided at the health facilities themselves. So it's important that we're thinking through with the community where and how these outreach services take place. I just had this small example of like this initiative that's taking place in Nepal. So they have 16,000 immunization outreach clinics in Nepal, and usually a lot of times it's like they take place at like the village head's backyard or various places. There's no fixed place for them to do this. So what the government is doing is they're funding the construction of houses for these outreach clinics, and in partnership with the communities who are providing the land and the labor to create the clinic themselves. So as of now, I think, or I don't know if this is actually, to be, Leila can clarify, if we've actually have 7,000 fixed immunization outreach clinics now, or that's the goal in a certain timeline. But the idea is that they are community approved location and that the community was involved in building them. And Nepal is trying to make all 16,000 of the outreach clinics have a house within the next 5 years. Next slide. Brainstorming, measuring, and metrics. This is super important. We all wonder about it. Because this was a sort of a scoping exercise and we're really trying to gather what people are thinking even about what we could do to then measure, we had a lot of answers and not a lot of answers. So of course I would look to engaging with the data group on this and understanding maybe a bit more what WHO is doing. But we asked the question, here are some ideas in terms of maybe using quality improvement indicators around self-efficacy, measuring changes over time with comfort in delivering information as a proxy of quality of care, for example. If we move to the next slide, we had a lot of suggestions from the countries as to, once we figure out what those measurements and those metrics and those indicators are, possible ways that we could collect them through things that are already happening. For example, in like the DHS surveys, supportive supervision, mystery clients, satisfaction cards, community scorecards, anecdotal evidence gathering through community actors. So there's a lot of different ways we could collect it once we know what we want to collect. Moving forward, we're almost done here. I appreciate you guys. I'm gonna probably go through this super quickly. These are some of the suggestions from the KIIs themselves as to what could be done in country around how to create a more people-centered immunization service experience. Each of the country slide decks that are in the Dropbox expand upon this a bit more, but there are suggestions around policies and governance, capacity building, planning of the services, as well as actions to potentially motivate and support staff. Next slide, please. And then the monitoring of the immunization service itself. And we talked about this a bit more, about feedback, about making sure the community is involved in monitoring the services, making sure that IPC, for example, is now part of regular job assessments and that the managers know how to do it. And then continuing reinforcement and support of community structures like female community health volunteers, for example. They are a trusted source for immunization information amongst the community. They bring the community voice to the health facility and committee meetings. A lot of the community health workers across these 4 countries carry a similar role. So it's really about reinforcing and supporting them to play this liaison and supportive role. Next slide. Some of the key terms, other key terms that emerged from our interviewing to potentially explore are compassion, respectful care, essential care, social accountability, self-efficacy, and rights-based frameworks. This presentation, I included some links in there. And then this last slide, moving forward. This is busy, but one of the things that we did in our interviews is we particularly with people who were not immunization specific, is we tried to ask them if there were other initiatives or projects that they thought could be useful for us to potentially investigate and learn from. And so this is a mapping of all of them that came out at the global and regional level on the left-hand side, then in Ghana, Kenya, Mozambique, and Nepal as potential ways to further explore how service experience is or isn't being carried out and across these different countries and areas. And in all the presentations I mentioned in the Dropbox, we include a slide on each of these that gives a little bit of a vignette as to what the initiative is and who's doing it and where. So there will be more information there. This is just an overall mapping. And the next slide is the thank you slide. So I know that that was a lot. I hope that for many of you, early morning people in particular, Fairuz, it wasn't too tough to follow along a long presentation like that. But we'll
Hey,
pause
this
here.
is